Department of Healthcare Access and Information webinar, Wildfire and Wildland Urban Interface Readiness for Healthcare Facilities, brought to you by the Hospital Building Safety Board's Education Outreach Committee. This is the first session of the HCAI Design Guide for Planning and Preparing for Disasters webinar series. Some of the topics that we will cover today include recognizing operational vulnerabilities during wildfire events, coordinating design with emergency planning strategies to reduce downtime during disasters or unusual circumstances, and how to determine if your facility is in a fire hazard severity zone. We have made today's presentation, as well as the HCAI Design Guide for Planning and Preparing for Disasters, available to you. Look for the section labeled Handouts or Materials on the right side of your screen and click the files to download them directly to your device. We are scheduled to be here about an hour, which includes a question and answer session at the end. If you have a question during the presentation, please type it into the questions panel of GoTo and we will answer them the best we can. Please be sure to keep your questions generic, however. If the presentation experiences transmission difficulties, please log out and log back in using the same login information sent to you by GoTo when you registered for the webinar. If we have transmission difficulties, we're going to do the same thing. AIA credit. In coordination with AIA California, you can earn 1 AIA learning unit by attending the entire presentation. If you have questions regarding continuing education units, please contact AIA California. A certificate of completion will be emailed to you from GoToWebinar to registered attendees who logged in and attended the entire presentation. Certificates will not be available from HCAI. Staff members from one office should register individually to receive separate logins and individual certificates. Today's presenters are Nancy Timmons, Chief Fire and Life Safety Officer for the Department of Healthcare Access and Information, Office of Statewide Hospital Planning and Development. Gary Dunger, Executive Director of Design and Construction for Cedars-Sinai Health Systems and a member of the Hospital Building Safety Board, and Janice Chung, Fire Marshal for Redwood City and San Carlos Fire Departments, and she is also a member of the Hospital Building Safety Board. Once again, thank you for joining us today. So without further ado, I hand the presentation over to you, Gary.
Thank you. Good morning, everybody. Thanks for joining us today. We're going to go through some really untypical stuff, some stuff that is very prudent and important in California, but is something that we don't necessarily come across on hospital construction projects all the time. But I'd like to start with a little bit of a history to kind of get us to the point where we are for today's presentation. Starting with a little bit of a history of the relationship with HCAI, OSHPD, and the Hospital Building Safety Board. Many people remember back when OSHPD was Office of Statewide Health Planning and Development, Governor Newsom and the legislature created an Office of Healthcare Affordability, and that office was placed under OSHPD at the time. In doing so, that elevated the office in the government hierarchy to a department, and Director Landsberg at the time wanted to rebrand the office name to better reflect what all of the different aspects that OSHPD covered at the time. So the name was changed to the Department of Healthcare Access and Information, or HCAI. What was formerly the Facilities Development Division was also rebranded to Office of Statewide Hospital Planning and Development, and the roles and responsibilities of the former Facilities Development Division move forward as are current in place. The Hospital Building Safety Board is an advisory board established by statute that advises the director on application or administration of the Hospital Facilities Seismic Safety Act, and acts as a board of appeals with regards to seismic safety and fire and life safety issues relating to hospital facilities. The board comprises of 16 appointed members, 6 statutory ex officio members who represent all the different state agencies, and then 3 additional ex officio members appointed by the director. This board maintains close contact with professional groups and important industry organizations to bring attention to changes and emerging issues occurring in the design and construction of healthcare facilities to the office. Trying to advance, here we go. So talking a little bit about why we need a guide. Our webinar today, which is going to talk about Wildland Urban Interface, is an excerpt from the HCAI Design Guide for Planning and Preparing for Disasters. This guide was put together after the COVID-19 pandemic as a resource to evaluate what past practices and things that were learned during the pandemic to bring forward during provide information during other crucial times. It does quite a few different things. Of course, it provides various scenarios and design approaches for designers and owners for allowing flexibility for future design and construction. But it also does things like limit the anything go practices that were experienced during the pandemic. Ultimately, it boils down to providing a best practices guide for designing for facilities to be prepared during a disaster. The guide applies, man, I'm having trouble advancing, so bear with me a little bit. The guide applies to new facilities as well as major alterations for existing facilities, ultimately providing planning for the unknown. Hard to design for the unknown, and that's what this guide is sort of targeted at. It ultimately provides flexibility in various different design things, adapting existing systems for facility access, utilities, emergency projects, and so on, as well as for future design flexibility for future care options. Ultimately, it's a design guide that will show that designing beyond minimum code is going to be required. This guide's designed to be used by owners and operators, of course, design teams, local agencies, planners, contractors, and then, of course, other people who are involved in planning for future impacts. So a little bit of a history. It started during the COVID-19 pandemic, where all facilities got really caught by surprise and were struggling to find ways to provide safe environments for staff and patients that they were caring for. OSHPD was called upon to help mitigate and deal with some of these issues, like, how do I make everything negative pressure or 100% outside air and so on. Ultimately, and as a result of all this, there was some discussion about, was OSHPD going to change the code to incorporate these lessons learned during the pandemic? So OSHPD assembled a group of people knowledgeable in healthcare design, planning, code, etc. And the Emergency Design Task Force was ultimately created. This task force, come on, slide. This task force was tasked with identifying not just things related to the pandemic, but also other maladies such as wildfires. The lag is killing me. Such as wildfires, earthquakes, floods, and so on. And interestingly, it was determined that for normal everyday operations, current code was probably fine. But what about facilities that needed to be designed to incorporate or accommodate other types of situations? For instance, a pandemic resilient and ready facility. This design guide also addressed many of those options to prepare for the future events. The technology and processes learned were incorporated into the design guide and offered options such as switchable air volumes or redundant services, or incorporating new technologies into practice. And this design guide tries to cover all of those things. So with that in mind, this design guide has great cross-sectional application. Please advance. So, Janice, I'm going to take this one. I know this is the first session in the Hospital Building Safety Board Education and Outreach Committee 2016-2026 webinar schedule. So there will be 6 webinars provided that take different aspects and excerpts from the design guide and will be presented. And ours today, of course, is session 1, dealing with wildfire and wildland urban interface readiness. Session 2 will be an expansion of some of the things that we're going to talk about today, which is designing hospitals for wildfire smoke, scheduled for June 10th. Power resiliency webinar scheduled for July 7th. And then there are 3 additional ones that will be scheduled for later on in the year, dealing with infection control, hazard vulnerability analysis, and so forth. So the QR code you see in the top right is a QR code that you can use to download the design guide and make it your very own. And with that, Janice, I will pass to you.
Great, thank you, Gary. Oops, I think we skipped a couple of slides here. Apologies for the lag. Looks like we're going back to session objectives if we can. All right, so today's, oh.
This is crazy.
All right, so today's session is really intended to kick off a broader webinar series focused on healthcare resilience, infrastructure readiness, and disaster preparedness. But to start, we first need to, we can also see that we need to understand how wildfire risk is identified and how those risks translate into healthcare facility design and operations. So today we'll focus on 5 primary objectives. One is understanding WUI applicability. Another is interpreting Title 24, Part 7. Also identifying operational vulnerabilities and aligning design with continuity planning and improving coordination across disciplines. And the key theme throughout today's presentation is that wildfire resilience is not just one discipline's responsibility. It really does require coordinated planning. And the reason this conversation has become so important is because wildfire behavior itself is changing. So why does this matter now? Wildfire behavior is evolving rapidly. We're seeing longer fire durations. We're seeing more destructive fire behavior. We're seeing broader smoke impact zones and increasing strain on infrastructure and healthcare systems. And increasingly, we're realizing there really is no longer a traditional wildfire season. Wildfire is no longer a seasonal thing. This is really becoming a year-round operational concern. So one of the major lessons learned from recent events is that ember-driven ignition, and not just direct flame contact, is often the primary failure mechanism affecting buildings. And for hospitals specifically, the objective is not simply surviving the wildfire event. The real objective is maintaining operations during degraded or exigent conditions. So let's look at how our agenda today is going to be organized. We'll begin with talking about what WUI is and how fire hazard severity zones affect healthcare facilities, how Title 24, the new Part 7 applies. And from there, we'll transition into operational impacts, smoke readiness, and emergency planning considerations. So first, what exactly is the wildland urban interface? And what is the WUI? WUI stands for Wildland Urban Interface, and it refers to areas where development meets or intermixes with wildland vegetation. For healthcare facilities, this matters because wildfire exposure is no longer limited to remote forested areas. Hospitals may experience operational impacts from wildfire even when the fire itself remains miles away. Next slide. Once a facility falls within a WUI designated area, additional design and planning requirements may be triggered. And so with WUI designation, one of the important things to understand is that this is not just a map label or a planning exercise. Once a facility falls within a designated WUI area, that designation can activate mandatory code requirements tied to building materials, defensible space, vegetation management, and ignition-resistant construction. And these requirements can affect projects very early on, from budgeting and design assumptions all the way through approvals and long-term operational planning. Another important point is that wildfire resilience is a layered approach. There's no single feature or system that's going to solve this problem by itself. It's really a combination of exterior hardening, defensible space, infrastructure resilience, operational planning, and emergency coordination that collectively improves survivability and continuity. Next slide. So healthcare facilities will face several unique wildfire exposure pathways. Healthcare facilities will experience wildfire differently than many other occupancies. What makes this especially challenging is that several impacts can occur simultaneously. You can have smoke infiltration affecting indoor air quality, along with road closures that are affecting staffing and deliveries and logistics, along with utility instabilities and public safety shutdowns, degraded visibility, and ember exposures occurring all at once. And importantly, many hospitals experience operational disruption before flames ever approach the facility itself. So as an example, smoke alone can strain HVAC systems, impact vulnerable patient populations, and change how facilities operate day to day during an event. So wildfire disruption often happens without the building ever burning. Next slide. So why does fire hazard severity zone matter? One of the primary tools in California that we use to classify these risks is using fire hazard severity zone maps. One of the reasons why these are so important, because this can influence multiple aspects of both facility planning and long-term operations. There are a number of different factors to consider, including construction requirements, defensible space obligations, insurance and risk considerations, campus hardening priorities, and long-term capital planning. And for healthcare facilities specifically, many campuses evolve over decades through phased projects, additions, and renovations. So understanding wildfire exposure early helps organizations make smarter long-term infrastructure decisions. Understanding wildfire exposure early can help organizations make smarter long-term infrastructure decisions. Next slide. These designations can directly affect cost, materials, and project timelines. As wildfire severity increases, you can potentially anticipate construction requirement increases, material restrictions, approval timelines can take a little bit longer, and there's a redesign risk that also increases significantly depending on what zones that you're subjected to. So if you have early confirmation of fire hazard severity zones, this can help avoid costly surprises later on in the project. Next slide. So to help walk through how facilities determine their fire hazard severity zones, I'm going to hand this off to Nancy.
Thank you, Janice. So next slide, please. So how to determine if you are in a fire hazard severity zone. There are a couple tools to use, and one is right off of CAL FIRE's site. They have the map. You can use the QR code there to get to that. We also, if you can go to the next slide, please. We at HCAI Oshpod, we have our EOC map as well, but we'll get to that one in a second. But when you look at both of these maps, the SFM map and HCAI Oshpod, you know, I'm going to be saying, I'm going to want to say Oshpod first, but I'll try to remember to say HCAI first. But anyhow, if you look at both of these maps, you'll see the zones in the different colors. as well. So you have your high severity and your moderate. You'll see those different zones, your moderate, high, and very high in the different colors. And what zone you're in, there are going to be different code requirements that come into play depending on what zone you're in and what applies, which code applies, if does it apply when it's existing or is it just new, and we'll get into that a little bit too. But for now, just so you can use either of these maps. You can go to the next slide, please. If you go to our HCAI OSHPD EOC page, and you'll see this map, and you'll see on the right hand side you can get to the map layers. There's all kinds of information in there that you can toggle on or off, whatever you want to see. What are the evacuation zones, what the different layers on here, wind speed. It's not just for the fire. If you play around with that map and those map layers, you'll see all different kinds of items that you could turn on and off. So when you're over there, you could, if you want to see everything, go ahead and have everything on. It might make it a little bit harder to see, but you can see here that when you have the facility type that's shown, you can see the little blue diamond, that's your general acute care facility, the purples, the acute psych, the oranges, the SNF, the SNFs, the skilled nursing, and then you even have the yellows for the licensed clinics. So you can see those symbols right on the map and where they're located. And then the, let's go to the next slide, please. And when you toggle on to the one that says fire hazard severity zones, you can look at that. You can see all the different zones in there and the different colors like we showed on the previous slide, like what means what, and find the facility. You can zoom in on it. And this map, our HCAI OSHPD EOC map, is the same. It's going to be updated with CAL FIRE's map. So if they update their map, our map will also be updated. However, something to keep in mind is the local jurisdiction can go more stringent. So the areas are designated here on the map, but locals may have designated a area in a zone that's more stringent than what's shown on the map. So you have to make sure with your locals if your facility is in that zone. So don't rely on the map solely here, because again, locals can put it in a different classification that's more stringent than what's shown here, and that's not always going to be reflected on either of these maps. So you always want to verify with your local AHJ what zone your facility is in, and then that is going to be part of the design professional responsibility to get that information. So when you're submitting a project, check with your locals. It'll be on that item will be on our local AHJ form that some of you might be familiar with. We have that form that's about 3 pages long. It has various items on it with our crossover topics. This is an item that's added to the 2025 local AHJ form, where those are ready to be published. You should see those on our site hopefully soon. That will be on there. That will be for them to fill out. Hey, you know what? Here's what the map says, but we designated this area as a higher zone, and they'll put that on there, include that information on your plans. But again, that will be the design professional's responsibility. Use these as a tool, use these maps as a tool, but please check with your locals to verify that they didn't make that zone more stringent. And you can also use the little search button. It's a little teeny tiny. You'll see it on our map. You see where that red arrow is. That's not going to show up when you're Googling HCAI EOC map and looking at it, but there's a little tiny search feature there that you can click on. And if you want to just look for the facility by name, go ahead and do that. But I'll just say it just one more time. Please check with your locals to make sure that zone that you're seeing is the zone that they're actually in. And then we're going to move on to the hazards and the why, which is Gary, I believe.
Thanks, Nancy. So, as if wildfires hazards and whys are not self-evident. I'm going to pull us back into the hospital-specific aspect of the wildland urban interface. Next, please. From an operational perspective, of course, hospitals are unique occupancies. Obviously, operate on a 24/7 basis and have highly vulnerable occupants who have limited or no evacuation capability. So the challenges during a wildfire are inherent in that. And the fire department incident command group will need to account for this as the fire progresses and plan early. What's unique also about hospitals is that we operate on a regional basis, and a closure of a single hospital can have cascading impacts across the system. At Cedars-Sinai, for instance, if we had to evacuate the hospital, where could we send 1,000 patients? Because that's what our census is today. What hospitals who are also full in the region could accommodate 1,000 patients? With that in mind, design failures have a community-wide public health consequence, and that's why we want to focus on our presentation today. Next. Wildfires pose multiple challenges to a hospital, of course. Adding increased filtration, like a MERV 13 filtration system, can overburden the HVAC system. Killing outside air can have negative health effects if done over a prolonged period of time. Despite HVAC efforts, smoke infiltration still occurs, and that can obviously have a huge detrimental effect on respiratory challenge patients. Wildfires have a tendency of disrupting power by just destroying power lines that feed the facility, or through the public safety power shutoff process that the power company may do. Lack of power, of course, at a hospital has a huge implication. Other things like staff inability to even get to work to be able to take care of the patients, or limited access for supply deliveries, like, a fuel truck getting in to refill the generator. All these things are affected by the wildfire and are unique to hospitals that are generally going to continue to try to be operational during the event. With that in mind, that's why all of the code stuff that we're going to go on talk about today has huge implications. Next.
All right, so talking about code stuff, let's go to the next slide, please. So where did this all come from? So part 7, it has its own part now. Well, your part 2 is your building code and so on, but part 7 is new, but the information in it isn't necessarily new. There are some new requirements, but what you were used to seeing in part 2 in CBC chapter 7A, some of the information, a lot of what I'll be talking about these next few slides, that was from 7A, and that's moved over into part 7. But also this became kind of a one-stop shop for what was already out there. You have your like I said, CBC 7A, you have your CFC, your Fire Code, Chapter 49, Title 14, Public Resource Code requirements, the Health and Safety Code requirements, and the California Government Code. All that information was still out there. The user had to be familiar with what was in each of these to apply to these areas. So what part 7 does is just brings it to this one-stop shop, and it is based off of, like our other codes, is based off of the international WUI, and California took it. We made some changes like we do, and now we're here. So again, it's not necessarily, it shouldn't be new to you if you've been doing this for a while. It's just all now in one location for you. You go to the next slide, please. And where does it apply for the hospitals? It's to the hospitals that are in the WUI areas and the fire hazard severity zones, of course. really that comes down to that. It's if you're in the zone, then then you have to comply with these code requirements. But it's not applicable to existing facilities. But if you add on to the facility, that will have to comply with the CWUE requirements if you're in that zone. There's requirements for roof replacement. There's certain percentage over 12 months time. I believe it's 50% over 12 months time. That new roof, even if it's on the existing facility, will have to meet the new requirements. And then vegetation. There are requirements for the vegetation. So OSHPD, of course, isn't looking at the vegetation. So we'll have a lot of crossover topics with our locals. If you can go to the next slide, please. So with the vegetation, again, yes, that has to be looked at, but that's going to be on the local side. And the requirement in there now is, as you see here, that prior to the building permit final approval, that vegetation management needs to be approved. So going back to that local HJ form again, just like any of our projects that we have, or most of our projects, not every single one, but you got a new building, you're going to get a form from us, from our reviewers on that first review. That's your local HJ form with those 3 pages or so of the items that we would like them to look at. We give that to the design professional record on that first review. The design professional record sends that out to the locals. And this is a courtesy to the locals that we OSHPD are always going to look at, HCAI, are going to be looking at code minimum. But locals may have something else that they're going to want into place. So this form is that vehicle that allows them to say, hey, you know what, I've got a different requirement for my fire access road than what code minimum is. And they'll note that in there and we'll review to that. So in this form, again, they're going to be noting the zone that the facility is in, and they're going to be looking at the vegetation, but that's going to be the project that's submitted to them, that they need to look at that part of it, along with some other things. So if we could go to the next slide, please, we'll talk about some more of those crossover areas. As I already mentioned, the fire access road, that is one. We want to make sure that, do they need more than what code minimum is? But in addition to that, if they're in a CWUE area or fire hazard severity zone area, there are additional requirements that need to be met for that, for the fire access road. Water supply is, there are requirements that you're probably familiar with from CVCCFC Chapter 33 when the building's under construction for any building. But when the building is in a CWUE area, there are additional requirements for water supply during construction. So this is something that be mindful of, because the project's coming to us, we're looking at that water supply, but and you need that there before construction, but locals may want something different. So that's another one you want to be on that early on. And that the requirement is that the water supply is there prior to and during the time of construction. So again, that's something we need to look at early on along with locals. And then there is an exception though, if locals say, hey, we've got an alternate plan, we got tankers, we got what we need. There is an allowance there for the alternate. But again, just be mindful of the timing of this, is because you need that water prior to and during construction, we've got to have that communication with each other. So the approved water supply, how much do you need? When does it need to be there? We're looking at that. The standby, there needs to be standby power for that water supply. So you're gonna have, if you got the pumps on there, those pumps are going to need to be on standby power. So what's that going to look like? Because again, you need this prior to and during construction. So just pointers again, things that you might not be used to looking at till later in a project, you may need to be looking at earlier on. And then the address and marking, they need to know. That's obviously very important, but that's a crossover as well. That's going to be locals. There are specific requirements for the road coming up to the facility. That is going to be on the local side of review. And then once you pull onto, like if you're driving, once you pull onto the facility, we're looking at that with, but again, locals need to be on board with that as well. Next slide, please. I kind of just went through what the next slide actually is, but the again, the fire access roads is more stringent requirements like the width, the grade, the turning radius. As I mentioned, what's the required flow and the calculations that need to be there? What is that for when you're in a CWUI area? And are locals okay with an alternate, or do they want that there in place before construction? And then the backup power again. Next slide, please. And Janice already mentioned like what's the wildfire exposure pathways for the hospitals, or any facility really. Your embers, that's it. That's the huge one. Your radiant heat exposure, the smoke infiltration. We've talked about these things, and that's now where you come into, well, how are we going to protect our building from these exposure pathways? And then additionally, things to think about, like the blocked road access when you have a wildfire that can lead to road closures. Who can get to the facility? How that a lot of comes into play with that for operation and planning that we'll get to later on in the presentation. What's going to happen if you have a fire in the area and you can't get somebody to the facility, and you need fuel, and anyhow, we'll get to that. Electrical grid failure can happen as well. And go ahead to the next slide, please. But we'll stick with, all right, what are we doing to our building to help protect it from, hopefully beforehand, and then we'll get to what happens after. So a lot of, for what OSHPD and HCAI, what we're looking at, it comes to a handful of things. There's a lot that the owners are responsible for, design professional that looking at for the project as a whole. A lot of what's happening on the outside of the building, again, the vegetation, the access, the emergency water supply. But when you get to the building, what are we looking at? We're looking at roof assemblies. How are the eaves and soffits protected? What requirements are in play for the vents? The exterior walls and exterior wall coverings are two different things. You got your exterior wall assembly, but you also have sometimes your wall covering, and that's another assembly. So both those types of assemblies are being looked at. The glazing and the doors, a lot of times your exterior walls don't have to be rated depending on your construction type, but if you're in a WUI zone, then they may have to be. So what does that look like? There are requirements for the decks and projections from the building. The decks have their own specific requirements, and the projections have requirements within Chapter 5. Like, back up a little bit. So a lot of the information that you would find in CBC 7A in the previous editions, you will find in Chapter 5 now. A lot of that information. All the chapters matter, but a lot of the stuff that you find in 7A are now in Chapter 5. And a good resource is in the very back of Part 7. There's Appendix H. That'll give you a great cross-reference for what came from where. What came from Chapter 7, what came from Title 14. So, sorry, backed up a little bit there. Anyways, areas, there are special requirements for those. We're not getting to all those details and requirements for these components here today, but just know that those exist. And next slide, please. And they also, some of these requirements are going to apply to the accessory and miscellaneous structures that are adjacent to these buildings. So you may have something like a trellis. Never thought you really had to look at that before. If you're in a CWUI zone, then you will, or I should start saying the fire hazard severity zone, but whatever, both of them. You would look at these accessory structures, and they could be the trellises, patio covers, gazebos. They could be enclosed, they could be open, but depending on their location to the building and their size, there are requirements that come into these buildings have to be protected. So, for example, if the miscellaneous or accessory structure is less than 3 feet from their building, those are going to have to be, the accessory and miscellaneous are going to have to be constructed the same as your building, same construction type. If they're, then the code kind of, that give and take of the code, you get further away or smaller in size, then different requirements come into play. So if you've got an accessory structure that is greater than 120 feet, and it's between 3 feet and 50 feet to the adjacent building, then there are still requirements that that building, that accessory building has to meet, accessory structure has to meet. And that again may need the same construction type as the building it's the main building it's adjacent to. But again, I'm not going to go to every single point for that what's required, but that's something to keep in mind. And that's one of our crossovers again, because oftentimes those buildings are not going to be in HCAI or OSHPD's review. That's going to be on the local side. So again, a lot of communication is going to need to happen if you have these. Next slide, please. Just takes that a little bit further. Again, they may be enclosed or may not be. It's going to, you're going to be looking at the distance between the building and then the size of that structure, and different code requirements will come into play. Can you next slide, please? And we mentioned the decks already, but when you have decks, there are specific requirements for the decks that in 50473. And then awnings and canopies have their own requirements in Chapter 31. So you still have to go into the building code. You can't use CWUI in place of the building code. You still have your building code requirements. This is in addition to. So keep that in mind. And so when we're looking at canopies and awnings, they're in Chapter 31. There are still requirements for those. Decks you'll find here, but sorry about that. But anyhow, look in both. look in both of these. Next slide, please. And then for roof and eaves, that's of course, those are big. If embers are going to get into the vents, you're going to get underneath that eave, underneath those projections. There's requirements for these. Your roof's going to have your Class A roof covering. Again, remember that goes for those accessory and miscellaneous structures as well. They're also going to need that Class A roof, again, depending on their location. You can have open eaves, but there's going to be more stringent requirements for those. So the enclosed eaves are preferred. There still are requirements for those eaves. You have metal flashing at your roof valleys. You want to prevent the debris accumulation. So there's requirements for that, for the gutter protection, which of course we're not going to see that very much. But the vents, next slide, please. Requirements for vents, whether they're horizontal or vertical. They have to be tested per ASTM E286. Next slide, please. And there's also going to be a mesh opening requirement. What size can that mesh be on that vent? And then they have to be CSFN listed assemblies as well. So again, what that communication, we have your architectural specs. You got to make sure that matches your mechanical equipment and make sure all these requirements are in place. And next slide, please. And don't forget your spark arresters. There are requirements for spark arresters as well. And then for the walls, glazing and doors, they may need to be rated. So if they need to be rated, then you've got to meet all those requirements. So don't just stick, again, you got your crossover CBC, CWUI. You may have requirements or allowances in Chapter 5, 6, and 7 that no longer apply here because this is more stringent. So they may indicate, oh, you don't need to be rated because of your fire separation distance. But if you're in a WUI zone, now you're back to being rated. So making sure that you look at that and make sure your components are rated when they need to be. There's language for sealing gaps as well. They're in CWUI. Next slide, please. We'll rush that through too much. And I think Gary will talk more about the MERV and the different requirements here for the filtration.
Thank you, ma'am. So talking about smoke readiness for healthcare, it generally boils down to filtration upgrades and indoor air quality monitoring. And without going into too much detail, filtration, upgrading filters to the MERV 13 or better if the air handling system isn't designed for that, that can put a real stress on it and may not even be a possibility. Indoor air particulate monitoring is also something that will be needed during these wildfire or smoke events. And the consideration of establishing clean air smoke zones when possible in critical areas. Having the availability of these MERV 13 filters or other filters needs to have a strategy, and ultimately, and of course, the filters need to be on site and available when the event happens. So planning ahead of time is important for that consideration. Next slide, please. Points to consider when planning for smoke readiness include reduction or elimination of outside air intakes for a period of time, if making sure that the building doesn't get sick. Increasing airflow throughout the facility or in designated areas like waiting rooms, emergency departments, ICUs, ORs. Maintaining and being cognizant of the pressure relationships during this time to maintain infection control considerations, and then increase filtration. We've talked about MERV 13, but carbon filtration might also be an option, which of course requires even more horsepower from the HVAC system. Something to bear in mind, of course, though, is pandemic operations are fundamentally different than smoke operations when it comes to HVAC. So having the flexibility to switch from positive pressure to negative pressure to 100% outside air is all part of this important consideration. The session 2 webinar, which is scheduled for June 10th, is going to go into much greater detail on this topic. So make sure to have June 10th on your calendar. Next. The use of portable filtration or cleaner air spaces is something that can be done. It needs to, of course, be planned early. These HEPA filter systems come in all different sizes. They can be used to clean the air in a single room or in a critical area, and need to obviously be in place before the event. Next.
All right. Well, thank you, Gary. What we've heard so far is that smoke readiness and filtration planning require both technical design and operational flexibility. So now I'd like to transition into a broader operational and emergency planning considerations that we should take during wildfire events. Next. This next section shifts into the discussion from building hardening to operational continuity and emergency planning. At this point, the question now becomes, how do we keep hospitals functioning under stressed, exigent conditions? Because during wildfire events, facilities can be dealing with degraded air quality, staffing shortages, infrastructure strain, regional evacuations, and increased patient demand simultaneously. So what would be good is for you to start testing before the wildfire season. And one of the most important things facilities can do right now is to do that, increasingly before these wildfire conditions emerge at any point during the year. So that includes HVAC, smoke modes, damper controls, pressure relationships, filter seating, and sealing, and identifying operational weak points. You don't want to discover these system failures during a wildfire event. You want to identify these vulnerabilities during planning and testing, and not during an active incident. Next. For smoke readiness planning really requires coordination between facilities, engineering, infection control, operations, and emergency management teams. And it's not simply just about changing filters. You really should be thinking through how HVAC systems will operate during these different scenarios, during prolonged smoke events, where vulnerable patient populations might need some additional protection, how that indoor air quality will be monitored, and what operational adjustments may need to occur over multiple days. Another important consideration is the staffing's familiarity. Even strong technical systems can struggle if staff are unclear about operational protocols, escalation pathways, or smoke response procedures. And written checklists and exercises become very important. Next. One challenge we continue to see is that many backup power assumptions were not originally developed around prolonged wildfire conditions. Historically, generator planning may have assumed relatively short duration outages, but wildfire events can disrupt power infrastructure for extended periods and sometimes well beyond your traditional assumptions. So facilities should take a look at generator runtime duration, fuel supply logistics, increased HVAC electrical demand during smoke events, and how load prioritization decisions can affect patient care operations. More importantly, wildfire conditions can also affect fuel delivery itself through road closures, regional demand spikes, and transportation disruptions. Next. One of the difficult realities during wildfire events is that hospitals may experience increased demand while simultaneously operating under a cascading impact or degraded conditions. You can see more respiratory illness presentations, displaced community members, nearby facility disruptions and outages, and staffing shortages all at the same time. So surge planning is not just about finding more space. It's about maintaining a safe operation while that demand is increasing all around you. Next. This is another area where operational planning becomes very practical, and partnering with your local fire department or emergency management is going through a pre-fire plan or practice drill, and doing these things can help. During regional emergencies, facilities might need to think differently about patient arrival patterns, traffic flow, ambulance coordination, and exterior screening or triage operations. Even simple things like, what does protected outdoor triage space look like? What does that setup look like? What does clear signage look like? Do we have those ready? Or separating ambulance and walk-in pathways can significantly improve operational flow during high stress events. Next. And internally, compartmentation strategies can provide additional operational flexibility. Compartmentation can help you to isolate operational impacts in a shelter-in-place scenario. This would support relocation within the facility, smoke isolation, and continuity of operations during emergencies. Next. And to close us out, Gary will discuss shelter-in-place decision-making and final operational continuity considerations. Gary, are you off mute?
Thank you. I told everybody to make sure to unmute yourself and then didn't do it. Janice, from your previous slide, webinar session number 4, which hasn't been scheduled yet, coming later this year, will go into much greater detail about designing the facility for these types of events and designing the facility with these patient arrival and smoke compartmentation designs in mind. Thanks. Go ahead forward, please. So talking about that shelter and that strategy for evacuation, you know, by design, hospitals have a default strategy of shelter in place. You cannot realistically evacuate hospitals unless the threat is to the point where literally the building's catching fire. There are lots of different related challenges, of course. You know, some of the decision factors that weigh in are indoor air quality, the structural status of the building, power, road access, so on. Shelter in place is also supported by the actual design of the building, the envelope integrity, how the HVAC smoke protection system is working, is the backup power adequate, and so forth. But facilities will only evacuate when they absolutely have to, and this is through coordination with the incident command team, the fire department, and emergency medical services agency. But the key point here is designers have to prioritize this in-place protection over evacuation reliance in their thinking of the building design. And bear in mind that, you know, evacuation of ventilator dependent patients is probably going to place those individuals in a medically disastrous situation. Next, please. If your facility is located in a wildland urban interface, now would be the time to begin identifying alternate care sites. You know, off-site surge locations need to be identified and put in place in advance. Need to evacuate the availability of utilities and ventilation capacity, but understanding that these remote sites are resource intensive and are certainly not ever a first choice, so as a last resort. Next, please. So from an owner's perspective, what can I do now? What are the things I need to be thinking about now? First, look at your fire hazard severity zone designations, both the state responsibility areas and the local responsibility fire hazard severity zones. Verify what your facility zone is in, and be aware of those contingencies and exposures. Conduct a vulnerability assessment of the exterior of the building, and then update the hazard vulnerability assessment of the entire operation. Review your generator capabilities and fuel supply. I could tell a story about a hospital in Southern California during one of the fires where literally the fire burned to the exterior walls of the building. They lost power. The generators kicked on and everything worked great, except the fuel pumps from the underground fuel storage tanks were not on emergency power. So when the day tanks ran out of fuel, the hospital went black. This is something that obviously needs to be identified early. Test your HVAC smoke mode. Do it regularly and have schedules to test it and make sure everything's operational. And then, of course, aligning capital projects with the WUI requirements, which flies into the next slide. For design professionals, next please, I'm sorry. For design professionals, these 5 items are kind of the pillars to ensure WUI compliance. You know, of course, confirm the wildland urban interface applicability and your fire hazard zone classification, and incorporate that into the basis, into the design, before schematic design. Incorporate those WUI requirements into the basis of design, and make sure that that understanding of the importance of the design is carried through the life of the project, and that all the team members are aware of it. Establish coordination protocols, of course, with all of the important design players, especially MEP designers, civil and landscape disciplines, to ensure that these comprehensive WUI integrations are maintained and, of course, designed and constructed. Align your design decisions with operational goals. This is pointed at the owners. Owners need to be involved in the design and stay involved in the design and the construction of the facilities in these wildland urban interface areas. Owner involvement is really critical and key. And then lastly, of course, engage the facility leadership on the resiliency strategy. Owners need to not only be involved, but share their operational goals, needs, and design requirements for the entire development and construction of the building. Next, please. This is our last slide, and so we are now at time, but if there are any last minute questions or answers, we would love to give it a shout. I've been looking at the questions that were entered into the GoToWebinar. A really good question was asked: how does a designer determine if a hospital is classified as an essential facility, for instance, a risk category 4? Great question. The answer is for OSHPD 1 and OSHPD 4 facilities, Chapter 16A applies, so see Table 1604A.5. But for OSHPD 2 and OSHPD 3, and OSHPD 5 facilities, Table 1604.5 designates which risk category your facility falls in. I'm not seeing any more questions in the questions or chat threads. And since we are at time, why don't we be respectful of everybody's time? We really appreciate your attention and participation today. Can you advance to the next slide, please? This is our contact information. If you ever have any questions about any of the content of today's presentation, feel free to reach out to us individually. Questions can also be submitted to the regs unit at oshpod.ca.gov for questions related to code that might be specific to Wildland Urban Interface as well. With that, Yvette, I will pass to you.
Thanks, Gary. So this brings us to the end of our presentation. We hope you all found this webinar to be super helpful. Please remember, if you didn't download the PDF slides, you can do so right now by finding them under the handouts or materials section of your screen, including the contact information that Gary just gave you. If you have any questions about this particular presentation, send those questions to HBSB support staff at hci.ca.gov, and I'm going to put that in the chat right now. It has been a pleasure being with all of you today. Thank you for what you do and for doing your part in providing access to safe, quality healthcare environments throughout the state of California. Thank you so much, and you take care.